I am a consultant in paediatric dentistry, and what I'm doing is I'm just recording this session that originally I delivered on Monday the 7th of June, and I'm just re-recording this to share as a resource. And what I'm talking about is dental or oral neglect, and this is part of the whole Neglect Matters focus week. So what would I like to talk about? What I really want to talk about is just give you some background about what I do as a paediatric dentist, to then further explore why teeth matter and teeth are important and what can go wrong with teeth, how safeguarding relates to dentistry, to then talk specifically about dental neglect and how that fits in with overall neglect or abuse, what our professional duties are, and really the aim of this is that at the end we can all of us at least take away one sort of action to make a real positive change. And why the jigsaw here? I just think what we're talking about is like everything really that we do in healthcare. It's about having all the information and all the pieces to give the most accurate picture, which means that children and their families are looked after the best way possible. And that's the thing that we all want to do. So paediatric dentistry, what is paediatric dentistry? Paediatric dentistry is a specialty within dentistry where we look after children from birth up until 18 years of age. So this is a huge range. It might be a baby who's born with a tooth, or it might be a sort of stroppy teenager. It goes the whole way. And often it's for more than one reason. And how do we get our patients? Well, the usual route is we get them from their own general dental practitioner, their own GDP. It might be from a community dentist, or it could be from other healthcare professionals like health visitors, paediatricians, and so forth. And why are they sent to us? Usually it's because they're anxious, and therefore they might need some treatment with sedation. They might need to be asleep and have a general anaesthetic. And the child that we see, they might be healthy, or they may have a medical problem like a bleeding problem, or be an oncology cancer patient, or it may be that they have special needs and, for example, have something like autism. And all the time, we're safeguarding our patients. So the landscape, as I alluded to previously, is really that spectrum of the baby, the toddler, the child, the adolescent. And each of these groups provide different challenges. And also remember that children have two sets of teeth, so they're different to adults in that they have their baby teeth and then their adult teeth, which start coming around the age of 6 to 12. And also with children, we have to consider parents. And what we're wanting to do as paediatric dentists is we want everyone we see to have oral health, or for that to be re-established. And oral health, as defined by the Department of Health, is as shown here. It's the standard of health of the oral and related tissues, which enables an individual to eat, speak, socialize without any active disease or embarrassment, and it contributes to their general well-being. So that link is already obvious there. Now, do teeth matter? People think, oh, does it really matter? Especially there is this whole thing about baby teeth. Oh, they're just milk teeth, they're just baby teeth, they don't matter. Well, actually they do. And teeth matter in the lives of young people and families. Why? Well, any of you who are parents or have nieces, nephews, friends, children, there's this whole thing, oh, they've got their first tooth or they're teething. Then when children start to get wobbly teeth and they lose them, will the tooth fairy come? Will they bring them money? Or they've left them a note? And then we'll have braces. And teeth matter because if you look at this diagram here, any problems with baby teeth, if there's infection or if there's been trauma, it can damage the underlying teeth, especially if it's less than the age of 3. Teeth are important for chewing food, so for function. Teeth are important because your smile is a thing that's really important in a person, and for health. So you've got the tooth. What can go wrong with teeth? Well, thinking about the tooth structure, you've got your tooth. What can happen? The tooth can get holes in it, so you can get dental decay, dental caries, we call it. You can get trauma where the tooth is broken or the root. You can get anomalies, which is unusual things with teeth, and the anomalies can be in terms of the number of teeth, so you can have too many or too few teeth. The size might be wrong, so there might be big megadonts or small microdonts. It might be the shape of them, and then the form. So as the teeth form, the layers don't form as they should. Then it might be orthodontic related, so you might have an impacted tooth. It could be the way the teeth bite together. Then you've got problems with the oral mucosa, which is the soft parts of the mouth. So it might be that you get an ulcer or a lump or bump. Then you can have gum, periodontal things, and pathology like cysts and things in the jawbone. So lots of things can go wrong with the teeth. Now, this is an example. I shared with you the names of the things that can go wrong. So what we have here on the left are 3 pictures of what dental decay or dental caries, what that looks like. You can see sometimes it looks black. Here it's more kind of yellow-brown. These 2 pictures in the center at the top, this is dental trauma. You can see here that the trauma, this tooth has been moved, this tooth has gone, these teeth are broken, and also the soft parts have been damaged, the lip around the mouth. Here we have what's called amelogenesis imperfecta, imperfect enamel formation. And this is an anomaly of the tooth structure. These teeth, they look different, so there could be a source of bullying, and also these teeth might be sensitive or they can chip. Here we've got someone with what's called an increased overjet. These teeth stick forward. They would benefit from a brace, and actually a child like this is more likely to bump those teeth, but also they might be teased. And then finally, the 2 pictures here are where we've got the anomalies of number. Here in the middle, you can see we've got this extra tooth, this supernumerary tooth. Here on the bottom right, this child has got lots of missing teeth. Those adult teeth, the teeth will never fill the spaces. So actually, this is quite hard for a child if you've only got these number of teeth. So teeth do matter. So going back to dental caries or decay is largely preventable, and it's a huge health inequality. Holes happen in the teeth because you've got your tooth surface, you've got sugar, you've got bacteria, and over time, holes are made. And when a tooth has decay, even though there has been huge advances in medicine dentistry, if the hole is large, the tooth has to come out. We might fill, and sometimes we might monitor if it's a very small hole. There's a huge manpower and finance attached to dental caries. And as most of you will probably know from headlines, is that the extraction of decayed teeth is the most common reason for hospital admission of children in England. And the numbers are huge for this, and especially in the age 5 to 9 age group where they're rising. Now, how do we know this? Well, the last big sort of study that we have is the 2019 Public Health England epidemiological study. And this study showed that you can see here that the prevalence of experience of dental decay in 5-year-olds is almost a quarter across all the regions. So it's sort of one really in 4 5-year-olds having decay, and in some areas it's higher. So for example, in the northwest it's very high, Yorkshire and the Humber, and you can see that here. And over time, if you look here, I've put some arrows because the last study that was done, over time in some areas it's been going down, but actually we've seen an increase in the dental decay in 5-year-olds in the southeast, the east of England, southwest London, England here. So those numbers, the 5-year-olds amount has increased. If you look at 5-year-olds, what we looked at, and this is just showing you here, is that a % of children have what's called oral sepsis. So they actually have an abscess infection in their mouth, and that's on average about 1% of children, which is significant. They're only 5. And then when we look according to deprivation, the most deprived have the most amount of dental decay, which we know, and the least deprived have the least. So we know, as we said, dental caries is a health inequality. The other thing is dental trauma. I just want to take a moment to mention dental trauma. Dental trauma happens more in males than females, and about 50% of children experience trauma. But you might not always know that, because sometimes children we know have bumps and bangs, but they might not necessarily go to the dentist. There are certain accident-prone ages, so you've got children when they're just learning to walk and you know that they fall a lot, and then around the age of 7 to 10, when children are kind of participating in more at-risk activities, so they have their bikes, they have their skateboards, trauma is more likely to happen. And with trauma, the treatment that you provide at the time can often directly relate to the long-term outcome. So if the right treatment isn't done, or if it's not done at all, then that can mean that the child is more likely to lose a tooth later, especially for big injuries where the tooth is knocked out of the mouth, or a big twist like on the tooth on the top right here. And also, as dentists, you'll know that there's the link between dental trauma and non-accidental injury. because with physical trauma, you have to think if somebody has a trauma, does it fit with what we see, or is there anything that we're worried about? Now, having talked about everything that can go wrong with teeth, to have optimum oral health, what are the 4 essential components? Well, they're shown here in purple. Number 1 is fluoride. Children and young people need a regular source of fluoride, and that's usually supplied by twice daily use of the fluoride toothpaste. When you brush, you have to spit. You don't rinse because it dilutes the effect of the toothpaste. And in the past, some of you may have had fluoride treatments and things, but we know now that fluoride acts by being in low concentration in the mouth. So it has to be twice a day, and you spit after brushing. Diet, really, the mouth can't recover if it's continually getting sugary drinks. So the frequency is the important thing. The mouth can recover from 3 or 4 sugar attacks in the day, or kind of when you have your meals, but in between, that's when things happen, and especially all night. And also diet has an impact on health burden in terms of obesity and increased incidence of type 2 diabetes. So it's related to that as well as dental decay. Oral hygiene, the physical act of brushing the teeth, is essential for oral health. And lastly, dental visits, because then a child will benefit from preventive care, and any treatment when needed, it will be picked up rather than it advancing when it's more complicated. So going back to the initial objectives, we said, why does safeguarding, how does it link to dentists? Well, safeguarding that we're all doing here today, whether we're police, education, health, we are all acting collectively to protect our children and young people from maltreatment, and also to prevent impairment of their health. Now, dentists specifically, in terms of child protection, the first document that was sent out to all dentists in England was back in 2006. And this was a document called Child Protection in the Dental Team. Following on from that, in 2009, there was a policy by our society. Here it's the BSPD, which means the British Society of Paediatric Dentistry, and they talked about dental neglect. Then we have the NICE guidance in 2009, which was called When to Suspect Child Maltreatment, and they referenced specifically dental attendance. And then coming up to date, we had the 2013 Cardiff Systematic Review. And then in 2019, the British Dental Association Was Not Brought toolkit, and then Public Health England, they did a toolkit for dental teams in practice. But for safeguarding for all of us, it has to be holistic. It's not dental education, it's everything, because the child's at the centre, and also their context, and that's really important to think of. So what are we thinking about with the context? Well, all of us, irrespective of agency, excuse me, we have to be effective partnerships, and we have to have a joined up approach. We all share similar challenges, and that is COVID, having time, families are complex, the reality of the challenges about thresholds when critical versus lived experiences can be different, opportunity, knowledge, and sometimes as agencies, our perspective differs, and that can be difficult. But the common focus which we have to keep our mind on is the child or young person who is at the centre here. And they are impacted by parenting capacity. So is there anything about the parent that impacts on them, their family and environmental factors, and the child's developmental need? And we have a duty, whatever we're doing, to find out as much as we can around here so that that child and young person is safeguarded and their welfare promoted to the best of our ability. So specifically, what does that mean? What do we do as the dental team? What it means is that we have to ask the questions. Who is the child with? Have they had any pain or problems? Is their life been impacted by their teeth in any way? And we have to assess and recognise the things that can go wrong with the teeth that we shared. And often there's more than one presentation. What do I mean by that is the child might present with a hole in the teeth, and they might have had a dental trauma. We have to layer, like all of us do, and something that we think about might turn into something or nothing, depending on what we find out. So that might be someone you think, oh, was this interaction between the child and the parent odd, or something about this doesn't make sense? So we'll get more information and gather information, unless obviously it's an emergency where you might have a drunk parent who's not able to safely take their child home, in which case obviously it's a police matter. Then we've got our role as dental team. We might be providing help or services as part of an agreed plan. So it might be that a social worker said, these children are in foster care, can you please see them? It might be that we're providing treatment because a child has had physical abuse. It might be sharing information. And in dentistry, the majority of referrals that we do tend to be Section 17s, where we've identified that the family need extra support. And we do all of this in an appropriate environment. Now, safeguarding themes and case examples that are real sort of things that we have is that there's often issues around parental responsibility. So if, for example, I'm operating on a child, we need to make sure we have consent from the right person. Also, consent to treatment can be an issue. What do I mean by that? Well, sometimes parents do not want to have certain elements of treatment. So a child might have a mouthful of decay. The parent might say, oh, you can do the teeth at the back, but you can't do them at the front. So it's working with families to get them to understand why we recommend certain treatment. It might be around trauma. So a child may have trauma and there may be a delay in presentation. How the parent explains might not fit with what we see, so that could be a worry. Then we've got people with missed appointments. We've got families who just don't take on board the preventive advice that we suggest. So we tell families to do things, and often siblings will have had dental decay or problems. We try and instill that preventive advice and they don't take it on board. Language barriers can make things difficult. And also now with COVID, because we're doing an increased proportion of telephone and video consults, then that can be difficult. Because we don't know who's in the room when we're talking. If the child isn't there, where are they? And it's just important to check. Now, actual case examples, what does safeguarding look like to us as dentists? But also, these are just 3 examples that I've had recently. So one, it was on a phone clinic last week where a family were sharing that they're living in cramped conditions and they wanted our help in sort of getting support for them to maybe for that change. 4 siblings, 6-member family in a 2-bedded place. Then I have a 15-year-old trans male whose mother has left the family home and gone to Ireland because she feels that he's brought shame on the family. He's out of school and mostly just doing artwork and says it finds it hard to chat to his dad about things. I'm managing for a jaw lesion, but that's complex and we're somebody who can provide support and help for him. And then the 3rd example is someone who is having sedation. So when they get the cannula in the hand, it was noticed that they had slash marks on the wrist. And what that turned out to be was they did that because they were feeling stressed about school and they felt like that was the only way they could get control about things. And actually this young person was having support, but it's still important for us to explore things because we might be the only person picking up these things. So moving to specifically think about neglect, which is our focus here. All of you listening here know what neglect is. It's the ongoing failure to meet the child's basic needs, and it's the most common form of child abuse, and that's as described by the NSPCC. We describe it in 4 main ways. So we have educational, emotional, physical, and medical neglect, and obviously dental neglect falls under that latter group. And neglect and dental neglect being linked is endorsed by big sort of associations like the British Medical and Dental Associations and the British Society of Paediatric Dentistry. In their document on neglect, which I talked about earlier, they specifically define dental neglect as the persistent failure to meet a child's basic oral health needs likely to result in the serious impairment of a child's oral or general health or development. Now, with everything that can go wrong with teeth, all of those different things, there can be an impact if it's not treated. So if somebody doesn't have a brace to correct their bite, that tooth might get broken because it's further forward. If somebody doesn't have treatment for their ulcers, it means that they stay sore. Everything can have a consequence, and the trauma, I said, it might impact on the long-term effect of the tooth. But here I'm just going to focus on decay, on holes in teeth, because that's the commonest thing with teeth. If we have decay and we leave it, it matters. Why? It matters because a child or young person might not be able to sleep properly, they can't eat properly, or they have to change their food preferences. They may miss school, which means the parents might have to be off, so they miss work, and a child might not be able to concentrate. They may, the pain or altered behaviours in a special needs child, so their patterns are different. We can have that damage to the adult teeth that I showed you in the diagram before. But more significantly, a child who's got holes in their teeth and has been left untreated, they can lose weight, which happens, and I've had patients where that has happened. Children can be bullied. They need repeated antibiotics. They might need more than one operation, which in itself has risks. And also, a severe acute infection can cause a life-threatening systemic illness. And you wouldn't leave infection anywhere else in the body, so you can't just leave decayed teeth. Teeth matter. Here, I'm not going to apologise. This is just to mention COVID and the impact on child dental services in the UK. This slide, is textastic, and really that's the point. Because there's been an article written in the British Medical Journal and also the Royal College of Paediatrics and Child Health in their 2020 report talked about the importance of oral health, but really there hasn't been big consideration to oral health and the impact on children and young people. Why am I saying that? Well, when COVID started back in March of 2020, all routine non-urgent dental care was stopped. Operating lists were stopped, so those general anaesthetics weren't happening. Then, even in June, when it all got going again, actually, there was not a great amount of capacity. Why? Because of the aerosols generated in dentistry and also because of PPE. So there was a general reduced availability. And what this really highlights is that the responsibility is not really dentists alone, it's all of us. That includes parents, schools, other healthcare workers, and we all have to work together to try and tackle kind of child oral health because it is a huge issue. So dental neglect, how might this present? What does it look like? Dental neglect might be a family where there's irregular attendance or repeatedly failed appointments. And we should be saying really was not brought rather than did not attend because the onus is not on the child. And then we've got repeated cancellations. And I refer to this as disguised non-compliance. And we know that in serious case reviews, a common thing is repeated missed appointments and cancellation. So it's usually a theme there. So, and also the sophistication of our electronic systems, and families know that if they miss an appointment, that triggers something, but if they cancel, it's very hard to pick that out. So it's important that we try and keep an eye on families where there are repeated cancellations. So for example, if we're doing a certain element of dental treatment, it might be that we need to do it in 3 to 6 months. They cancel twice, it might end up being a year, and then that tooth is compromised. Dental neglect may look like a child returning in pain at repeated intervals. They may need more than one general anaesthetic, and failure to access sort of organised care and their quality of life being impacted. Now, the big question that everyone always asks is dental caries neglect then? So if someone has holes in their teeth, is that neglect? And I think it's just not a black and white answer. So it's a spectrum, but there's things that we have to consider. So we have to be careful about miss or bad or non-information. You know, parents just might not know the right thing to feed their child or what to do. There might be long-standing cultural, socioeconomic and educational barriers to overcome. Is it intentional or non-intentional? And really, irrespective of agency, we want to work with families. Life is pretty hard for everyone and we need to try and support them. But I think the thing that would make us worried and we would consider to be neglect is where we've seen a child, we know that their teeth are having a negative impact on their well-being. If we said what's going on and we want to provide treatment to restore oral health and mean that their quality of life is improved, if a family failed to engage in that, we'd be very worried about that. So how do we manage neglect? We do it in 3 ways. We do it in a preventative sort of single agency or multiple agency response, or we refer to social services as shown here on the right side with the 3 things here, where the situation is too complex or deteriorating, where we believe it's in the child's best interest that we have support to ensure they get the dental treatment. So having considered all of that, what can we do together to address dental neglect? What we need to do is we have to have it as a priority. Prevention of dental disease, we have to promote oral health. We have to encourage the spitting, not rinsing after brushing. And I think that it's important that consideration is given to targeted water fluoridation schemes, which we know work, especially in the areas where we're seeing increased levels of dental disease still. It's training around the oral general health interface, and it's about everyone just having it in our heads thinking about teeth. It's awareness of us as paediatric dental teams for appropriate input on might be community or general dentists, and then cross-agency. In education, are we doing teeth as a topic? In the earlier sort of reception, nursery, key stage 1, are we thinking about brushing? Then we've got initiatives like Tasted, which is a charity where they will go into schools with fruits and foods and children can taste and smell them, trying to promote healthy eating. And then we've got social care. Is it mandatory that we record about teeth? The aim is that does it always happen? And irrespective of whoever we are, we should be saying, like do you have a doctor? What school are you in? Do you have a dentist? Do you brush your teeth? Because that makes the difference. Initiatives that are already in place, you've got the dental check by 1, so every child should be seen by the age of 1. Obviously, COVID was difficult for that, but that is the aim. We've got media, things like One Show, breakfast television. We've got Child Smile, which is a Scottish initiative. And then we've got Mouthcare Matters, or Mini Mouthcare Matters. And what that is that's children who are in hospital. And now actually this initiative has been extended to some hospices and some residential special needs sort of settings for kids. So that if somebody is in, for example, hospital, that the mouth isn't forgotten about. So if somebody needs help for them looking after their mouth, then you'll see the 2 elephants here in the corner. And then if they're fine, then it's just a big elephant because they're responsible for doing that. But at the end of the day, I think for big things like obesity, other things, the definite solution is that collaboration conquers. We have to all work together cross-agency, and we have to gather evidence data to really make a drive to improve things. And I think it's the fact that every contact counts and we have to be integrated. And what does that mean? It means that we have to ask the questions, we have to actively listen and converse with one another. And in the centre here, all of us as different agencies were working together so that oral health and health, that link and prevention, we promote it, all of us. That if there's generalised neglect, the mouth must be considered. And if we see unmet dental need, we have to share this and we have to try and signpost so the child or young person seeks dental care. And in this area, I have Mr. Candia, who works out of East Surrey, and there's an electronic referral system for them. But if we see something, we want to try and support that child to get to having their oral health restored, working collaboratively at the centre. So to summarise, what have we done? We've talked a bit about what I do as a paediatric dentist. Hopefully I've highlighted why I think teeth matter and the problems that can go wrong with teeth, why safeguarding matters and what that looks like as dentists, how dental neglect fits as part of overall neglect, that collaboration together we can make a real change. And what we have to do is we have to promote and integrate child oral health into all our professional practices, and we have to ask the question, and with all of those pieces and picking up red flags, we're going to improve things. So I would just like to say thank you very much for taking the time to listen to this. And if anyone has any sort of things they'd like to follow up on or ask, then my email address is shared here and I'd be very happy to do that. So thank you very much.